is going to speak on renal biopsy when and why. Very short introduction is done from MS Ramaya Medical College, MD and DM from Lucknow. He has got many publications and is also an experienced nephrologist. Over to Vinay Patri.
After the inaugural function and the orations in the morning, let's get to the business of understanding the important diagnostic tools in the field of nephrology, of which kidney biopsy plays a pivotal role. Slides, please. Yeah. So at the outset, I would be talking on a brief history, introduction, approach, why and when, how to proceed, how safe is the kidney biopsy in special population, and I will conclude. Brief history of renal biopsy. In the initial biopsies were taken place in a sitting position in 1951. As that marked post World War II, several innovations started, and that's how we started identifying many diseases and subsequent diagnosis. Kark and Morke introduced the Wim-Silversman needle. So, why exactly we need biopsy? To understand that, let us understand why renal symptoms are diverse. As we know, there is no specific one symptom that could point out to the renal pathology. So patients with renal diseases have diverse symptomatology with minimal clinical signs. They might present with symptoms or abnormalities detected on routine evaluation. Also, renal syndromes can present as a part of systemic disorder. A comprehensive history, examination, laboratory investigations helps in achieving at a particular renal syndrome. And each renal syndrome has a specific way of approach to arrive at a right diagnosis. Coming to the various renal syndromes, we have commonly which we encounter are acute or rapidly progressive renal failure, acute nephritis, chronic renal failure or chronic kidney diseases, nephrotic syndrome, asymptomatic urinary abnormalities, urinary tract infections, renal tubule defects, hypertension, nephrolithiasis, and urinary tract obstruction. Amongst the 9 to 11 syndromes in the nephrology, kidney biopsy forms a basis at least in the 6 to 8 of the syndromes. So, we have a patient with a renal disease. So, how do we proceed? So, once we identify the renal syndrome, we do routine lab and the urine analysis. So, subsequently, we classify based on the urine analysis patients having more than 3.5 grams per 24 hours as nephrotic, or if the patient has elevated BUN and creatinine, we call as azatomic. If the patient is nephrotic, for the PGs to understand, the nephrotic syndrome is a pentad wherein we have clinical edema, 24 hours urine protein of more than 3.5 grams per day, hypoalbuminemia, hyperlipidemia, and lipiduria. So for the azatomic patients, either we classify as AKI or rapidly progressive renal failure or CKD. Again, in rapidly progressive renal failure, we either classify as glomerular, tubulointerstitial, or vascular etiology. In AKI, we classify them as pre-renal, intrinsic, and post-renal. And the last identity is CKD. So now, why do we need a kidney biopsy? For a number of reasons. One, it helps us achieving the exact diagnosis and to determine the nature of the recommended therapy. That is first. Second, it ascertains the degree of active and chronic changes, wherein we can identify potentially reversible changes or irreversible changes in the kidneys. Third, the degree of active or chronic changes help to determine the prognosis and the likelihood to response of it for a particular treatment. Also, in any workup of a transplant prospect, we would always want to know the underlying disease as to in what exact nature was the disease present in the previous, in the native kidney disease, because there is a high chance of recurrence of the native kidney disease in the post-transplant period also. For the same reasons, this is why we always ensure that kidney biopsy is never missed in a patient suffering from the renal syndromes. The need is to diagnose, to have an extent of disease burden, and to plan for the treatment. Now coming to next, when do we need a kidney biopsy? We have 4 particular group of patients who would definitely benefit of having a kidney biopsy. One is nephrotic syndrome, as I already told, it is a pentad. So whenever you have a clinical practice, the patients come into a edematous illness of a acute on chronic illness, having urine albumin of 4+, with or without RBCs, plus or minus hypertension, with laboratory investigations fitting into having a low albumins of less than 3.5 grams per deciliter, 24 urinary protein of more than 3.5, and hypertriglyceridemia and cholesterol. So the diagnosis of nephrotic syndrome is made. So earlier days, the treatment would be straight away starting a steroid. And how different is it now? So any of the pathology which we have in nephrotic syndrome, the treatment differs as to underlying as to having the underlying pathology, because the treatment varies with various types of pathology. For minimal chain disease, it is steroids. FSGS, it is steroids. Sometimes we have to add CNI, sometimes we have to add MMF, or we also use biologicals. And for IgA nephropathy, it's a single therapy. And for other therapies, either we usually go with a single monotherapy of corticosteroids or involvement of CNIs or MMF or rituximab. For that case, we should always have the pathological diagnosis of a nephrotic syndrome, not to directly start with the steroids. In the next context is a renal disease in the context of a systemic disorder. The systemic disorder can be of vasculitis or lupus nephritis, or even in a diabetic patients. So commonly, many of the diabetic patients do have microvascular changes presenting as retinopathies, nephropathies, or a neuropathy. So in diabetic patients, when do we suspect or when do we think that there is a diabetic nephropathy in the background, on top of which we have to suspect of a nephrotic-like illness in the current patient? The first scenario is a type 1 diabetes mellitus patient. In type 1 diabetes mellitus patients, usually there is a long duration of diabetes onset. The patients usually have a microvascular changes already present in the retina, followed which they have a nephropathy. If in case, if the nephropathy occurs earlier in the diabetic patients, so think of a underlying basic nephrological issue than labeling it as a diabetic nephropathy straight away. So in type 1 DM, no retinopathy but nephropathy of any proteinuric quantity warrants a kidney biopsy, because many of the non-diabetic kidney disease, we have a large series wherein we have seen that IgA nephropathy is the most common cause in a diabetic patients having a non-diabetic kidney disease. Similarly, membranous can also be present. So never miss out a patients of type 1 DM without retinopathy but has a nephropathy. So this is in type 1 DM. How about the commonly what we see in type 2 diabetic mellitus patients? So type 2 diabetes mellitus patient does not actually follow the normal course. So these patients might have retinopathy or might not have retinopathy, and nephropathy will be present. So in such patients, nephropathy, think of a kidney biopsy wherein the 24 hours urinary protein is more than 10 grams. So we call massive proteinuria. A massive proteinuria in a type 2 DM, it warrants a kidney biopsy. Retinopathy, if it is not there, yes, it is still warranted. Presence of RBCs, that we call it as an active urinary sediment, RBCs or RBC cast, always indicates a proliferation in the GBM. It also warrants a kidney biopsy. Or there is rapidly worsening creatinine in a patient of diabetes mellitus without having underlying infection. So such patients also have a such patients also merit in a kidney biopsy to know what alternate pathological process is going on. Next subset of patient is acute renal failure. In acute renal failure, as we know the pathology, usually it is a reversible condition. 80% of them reverse within 2 weeks course. However, in patients, acute renal failure can be of any cause. In general, if there is no reversibility seen, or if the patient tends to be oliguric for more than 3 days, then such patients will require dialysis. To understand what is the pathological process in such patients, we require a kidney biopsy, or even once the creatinine starts peaking up and over a period of time it starts dropping down. However, if there is no reversibility of creatinine or the creatinine doesn't touch back to normal, then in such patients also kidney biopsy is warranted to know the extent of the disease. Why we should not miss out a patient of ARF? Because if we don't treat them at the earlier stage, 30% of the patients who we label as CKD at our first presentation would have actually had some insult, landed up in ARF, not diagnosed well, they land in CKD. So once the CKD is established, it is a progressive disease and there is no reversibility. So we should never miss any patient who comes to our clinic with elevated creatinine without any known stress factors. And the last subset of population is the renal transplant patient. Any patient who has a renal transplant, in the post-op period, any rise in the creatinine, we would always go for a kidney biopsy to look for any rejections, whether it is a cellular rejections or a antibody-mediated rejections. Also, some patients with non-nephrotic proteinuria. Many times you see no diabetes, no hypertension, patient comes to you with some edema, might not be present, might be present, but in the urine routine you see 2+ or 3+, you quantify them, 24-hour urine protein is less than 1 gram or 1 to 1.5 grams, there are no RBCs, no pus cells, creat normal. So what do you do? So even in such patients, the initial what we tell is to observe them, start them on ACE inhibitors, try looking for any reversibility with the ACE inhibitors. If there is no reversibility with ACE inhibitors also, we would advise for a kidney biopsy to know the exact pathology in the kidneys. And isolated hematuria, commonly seen in pediatric or a pubertal age group, also warrants for a kidney biopsy. Secondly, in adult or elderly population, wherein you are suspecting it can be isolated hematuria, can also be a precursor for any of the underlying malignancies in the males. And in chronic renal failure, as I already told, any patients who is going for a kidney biopsy, who is going for a kidney transplant, we would also always want to know the underlying pathology, what the patient was suffering, because the recurrence rates of underlying chronic glomerulonephritis post-transplant is very much. Supposedly, the patient had a IgA nephropathy or MPGN, that is membranoproliferative nephropathy, or a membranous. Post-transplant, if we have in the back of the mind that this patient was suffering from a particular disease subset, we can always think of recurrence of a disease. IgA has a highest recurrence, followed by MPGN, followed by FSGS. So, any post-transplant in the transplant workup, if available, kidney biopsy to be done. So, these are the various indications which I have told: nephrotic syndrome, acute kidney injury, systemic disease with a renal dysfunction, non-nephrotic proteinuria, isolated microscopic hematuria, any unexplained CKD, or any familial renal disease, and renal transplant dysfunction. So now what is the kidney biopsy procedure? How do we do it? Nowadays, with the invent of real-time ultrasound, we are always doing a real-time ultrasound kidney biopsy, and with the use of an automatic gun. So how do we work up with that? So first, any patients we have, okay, this patient fits in for the kidney biopsy, we work up for the renal imaging, 2 normal sized kidneys, unscarred, unobstructed system. BP is normalized, urine culture is sterile. Coagulation status, we always check for any of the coagulation parameters are abnormal. Any drug intake that we see, and we plan for a kidney biopsy. Again, the checklist. So what are the contraindications for the renal biopsy? Kidney status and the patient status. If the patient has multiple cysts, kidney biopsy might not be possible because the chances of bleed is very much high. Solitary kidney. Supposedly solitary kidney is there. So how do you go about it? See, single function kidney with no other kidney, in such patients, if the clinical diagnosis of nephrotic syndrome is made, there are other laboratory tests wherein we can go to certain extent of the underlying pathology. Why? Because solitary kidney, the chances of bleed, although it is 0.01%, if it bleeds, and there is a chance of nephrectomy. So in such patients who have solitary kidney disease, if we are able to find the serological laboratory marker in the blood, we are not going for kidney biopsy. Acute pyelonephritis, perinephric abscess and renal neoplasm. And patient status, any uncontrolled bleeding diathesis, uncontrolled BP, uremia. Such patients wherein we call it as RPRF, rapidly progressive renal failure. These are a subset of population who present very acutely, worsen over days to weeks. In such patients, as we know, uremia itself is a bleeding diathesis. It is a milieu wherein there is a coagulation disruption. So patients who have got high creatinine, they have a high tendency of bleed. So in such patients, what we do, we take them for dialysis, keep the creatinine at the lowest possible, and with all precautions, we go for a kidney biopsy. So these were the earlier Wim Silverman needle, and now we have automated spring-loaded devices, wherein these have particular gauges. The lesser the gauge, more the gauge, lesser the complications, but the yield of a tissue is very less. So this is how the tissue looks when we take a kidney biopsy, and this is how we do a ultrasound guided real time. We actually see the kidney, cortex and medulla is identified, and the needle is put. We ask the patient to hold the breath for 5 seconds, ensure that the needle is sitting just above the cortex, and we shoot the gun. So the gun, once it shoots, it cuts the core of the cortex, and we take it back. And we retrieve the gun, and once we retrieve the gun and we pull one of the levers, we get this tissue length. So adequate tissue length is around 1 centimeter, and we usually do a check scan with the microscope, light microscope, and see at least there are 8 to 10 gloms are visible and 2 arteries are there. We say that the biopsy sample is adequate. And we transfer the kidney biopsies. We take two cores, one for the formalin sample and other for the immunofluorescence. So without immunofluorescence, our kidney biopsy reporting is incomplete. Once we send it for biopsy, the pathologist reports under the various heading of glom, tubules, interstitium and vessels, and IF staining for immunoglobulin G, A, M and C3 and C1Q and C4. Coming to the procedure, how safe is the kidney biopsy? This is a meta-analysis review which was presented recently. Total 87 manuscripts, total number of biopsies were more than 1 lakh. Age group was 30 to 80 years, 45% female. So as you see, 11% had hematoma, which is quite common. 1.6% required blood transfusions. Pain at the biopsy site was 4.3. Bleeding requiring intervention. Yes, sometimes if it bleeds, there is a formation of AV fistula. Also, the rupture can be severe and it requires intervention. Usually we intervene with DSA. Either we go for coiling or angioembolization, or we apply or a glue. Death is very rare, maybe 0.06. So in conclusion, the native kidney biopsies in invasive diagnostic procedure, the rates of bleeding complications are low. So although the rates were high in patients with hospitalized patients or in acute kidney injury. The percentages wise of the kidney biopsy complication: visible hematuria 3.5, need for blood transfusion 0.9, need for intervention to control bleeding which 0.7, and death is very rare, that's 0.02. One special population consideration where kidney biopsy is required is in pregnant females. Kidney disease affect in 3% of women. What we usually look for is any worsening of proteinuria or renal dysfunction or hypertension. The stage of pregnancy, kidney disease severity and suspected underlying diagnosis. So as far as possible, we try to avoid any kidney biopsies in pregnancy in whatever stage. If at all we are able to come to a conclusion in the clinical history itself, we start appropriate treatment. Even if you want to go for a biopsy, the usual trimester is late first trimester or early second trimester. More than 28 weeks, we go for empiric options of steroid and azathioprine. In conclusion, kidney biopsy is safe, although it is invasive, but a must for a definitive diagnosis. It helps in treatment plan and prognosis. Just to recapitulate what I said in the earlier, nephrotic syndrome, for adults, kidney biopsy is a must because it not only tells us the exact pathology, also it will guide us in the treatment plan and the duration of the treatment. In children, sometimes we do encounter children coming to the physicians. In children up to the age of 12, we would not recommend kidney biopsy because most commonly it is minimal change disease and empirical steroids are offered. Unexplained kidney injury of any degree of severity, kidney biopsy is a must. Rapidly progressive renal failure, rapidly progressive glomerulonephritis, we would want to know the severity of the kidneys as to plan the level of immunosuppression and the plasmapheresis also if required. The last subset is a PIGN or a infectious related glomerulonephritis, or we also call it as acute nephritic syndrome. So acute nephritic syndrome is a subset of population wherein it is a self-limiting disease in up to 60% of the population. So you have a predisposing factor of upper respiratory tract infection or a skin infection, followed by hematuria, followed by hypertension. In such patients, the biopsy is not warranted unless there is worsening of creatinine over a period of days or the proteinuria is significantly high, or the patient has a very low C3 not responding to the routine treatment. In such patients, kidney biopsy is warranted in patients of acute nephritic syndrome. Thank you. Any questions? I would be
Thank you very much for extensive and lucid talk on kidney biopsy. As we are running short of time, any questions or doubts can be asked later. Next topic, please.
Our next session is on nephrology.
Timely and accurate diagnosis in infections relies on the use of various parameters, making them essential for effective management of the condition. We have with us Dr. Govindappa, who will be briefing about biomarkers in sepsis.
Yes, sir.